Good morning. Welcome to ECG's webinar, Health Systems Must Integrate and Rationalize. My name is Andy Backroat, a principal in ECG strategy practice, and I will be today's moderator. Our featured speakers today are the primary authors of ECG's Strategic Perspective White Paper, Health Systems Must Integrate and Rationalize. John Lutz is a principal at ECG. He has spent more than 30 years leading and advising healthcare delivery organizations through strategic enterprise transformation engagements, which yield significant and realizable performance improvement. Maria Finarelli is an associate principal at ECG. Maria's 25-year consulting career has focused largely on strategic planning, market positioning, and service line planning. Sean Hartzell is an associate principal at ECG. His experience in strategic and financial planning, service line development, and hospital physician alignment has made him a trusted advisor to providers as they navigate the complexities of an evolving industry. Before we begin the formal program, let's go over a few details about the webinar. Today's program will be 60 minutes in length. There will be 45 minutes of presentation and 10 minutes for questions and answers. Everyone should have received a copy of the session handout, but if you were a late registrant, you can download the handout in the handout pane on your screen. Attendees are participating in listen-only mode, but if you have questions, you can type them into the questions pane on your screen, and at any time, we will address them at the end of the formal program. If we are unable to answer all questions today, we'll follow up with you after the session. We will be launching some audience polls during today's presentation, and we hope that you will participate in this interactive measurement tool. And finally, upon exiting today's program, you will be directed to an electronic survey. Your feedback is important to us, so please take a minute to complete this survey. For each completed survey, ECG will make a $5 donation to Doctors Without Borders. Our We Believe series is designed to be a provocative call to action for what healthcare organizations must do now to ensure their sustainability in today's environment, and a future wherein we believe the pace of change and industry innovation will require, in the words of Lee Iacocca, healthcare organizations to lead, follow, or get out of the way. The first webinar in our series discussed how the healthcare economic model for providers is in critical condition and may get worse for some. Every provider organization must ready themselves to accept that the journey toward value must accelerate. Unless providers proactively drive change, they risk being marginalized to vendor status while sitting on the sidelines. Today's webinar and the accompanying white paper focused on the second We Believe statement. Specifically, we believe health systems must integrate and rationalize. Our premise is that health systems must lower unit cost of services and ultimately focus on improvement of every aspect of operations. Opportunities exist in both the administrative and clinical functions of all provider organizations, regardless of size, scope of services, and financial success. The vulnerabilities of healthcare economic model and the intensifying pressure to demonstrate better performance in conjunction with increasing scale have led some organizations to proactively address these opportunities. At this point, I'll hand it over to John.
Thanks, Andy. Redundancy, duplication, and waste are pervasive in healthcare throughout the United States. Coupled with significant amount of clinical variation within today's hospitals and health systems, operating and capital costs are continuing to rise. To achieve economic sustainability and market essentiality, we believe health systems must integrate and rationalize. If organizations do this, the future state will have enhanced clinical care, optimized operations, and lower costs, ultimately focusing on the improvement of every aspect of patient care operations. Later in the webinar, we will discuss 4 imperatives for health systems that are looking to advance their efforts in this area. But let's begin with definitions and an example or two. Integrate is defined as forming, coordinating, or blending into a functioning or unified whole. For hospitals and health systems, integration might mean implementing common operational processes and workflows, adopting evidence-based protocols and clinical pathways, and approaching decision-making with a system mindset. To rationalize means applying research-based managerial principles to make something more effective and/or efficient usually by combining or stopping particular activities with the appropriate workforce. In healthcare, rationalization is more likely to centralize corporate functions or alter the scope, mix, and/or distribution of clinical services. While benefits for patients and providers can be significant, reaching this future state isn't easy, which is why many organizations have been slow to start down this path. Providers across the country are at different stages on their integration and rationalization journey. Few healthcare organizations have addressed both integration and rationalization in a comprehensive, advanced manner. Most are somewheres in the middle, maturing stage, having accomplished some degree of integration, likely related to technology or finance, and potentially pockets of operations. Others, due to their smaller size, less complex organizational structure, and/or reluctance to face the challenges outlined above, have barely started and are in the developing stage. Pursuing integration and/or rationalization is difficult, as both call for examining and typically changing the way we've always done things. This is further complicated in multi-hospital systems or medical groups that reflect the combination of several disparate organizations. Challenges will be both internal, culture, leadership commitment, and resources, and external, in the form of community resistance, local political pressure, and state-specific regulations. At this point, I will turn the program back to Andy for our first polling question.
Thank you, John. Our first polling question reads, which stage of the integration and rationalization journey is your organization in? Please select one of the following responses. So this polling question will really help us get a sense from where the participants in this webinar are, and hopefully will inform some of the questions that you all may have as well, so that our team can respond to those as we work our way through the balance of our conversation here. And I suspect many of you may find that the pace of integration that your organization has been through may be accelerating. And that's certainly one of the themes that we've seen within the other webinars that we've conducted in the last recent weeks. So it looks like we've got a pretty good response rate here. So let's go ahead and close the polling and see what our responses look like. So it looks like we have 46% that are in developing, 54% that are in maturing, and 0% that consider themselves advanced. And that is certainly an interesting finding in and of itself. John, any thoughts on these results before we jump back into the presentation?
Andy, this is really encouraging to see that people have rated themselves and their organizations where they are, because our experience has shown that most organizations are really at the developing phase, and yet at the same time, many have made great strides, and so we would put them in the maturing category. So that's actually, it's very encouraging to see. So let's go back to the presentation. So in early 2020, before the impact of COVID-19 pandemic was widely felt, several industry trends were causing provider organizations to examine the need to integrate and/or rationalize. With about 10,000 people turning 65 every day, the aging of the US population will impact health care providers in multiple ways. Making a margin on Medicare volume, which will account for a greater percentage of patient revenue, will require wholesale changes in clinical operations to reduce costs. The change in payer mix, with a higher proportion of government payers, will also limit the ability to use margins from commercial business to offset the losses on Medicare and Medicaid. Regulatory changes are also increasing the pressure on health systems' bottom lines. Site of care shifts, including outpatient procedures moving to freestanding ambulatory surgical centers, and growth in digital health visits and encounters, will require providers to re-examine care delivery location options. CMS's site-neutral payment rates for clinic visits will further erode the revenue base. Consumers, particularly the 30% of covered workers with high deductible health plans, the underinsured, and those paying for elective procedures, are doing more price shopping than ever before. Success under risk-based pricing models requires close examination of clinical and operational processes to identify opportunities to reduce unnecessary utilization, minimize clinical variation, and eliminate waste. These efforts must lower both the per unit cost of care delivered and the total cost of care for the covered populations. Bundled payments are currently the most common model, but Medicare Advantage may be the next frontier of value-based opportunities. From a care delivery perspective, site of care shifts, fewer avoidable admissions, and lower readmission rates mean that hospitals in the future will be occupied by high acuity patients and those requiring complex, specialized diagnostic and therapeutic procedures. The aging healthcare workforce and projected shortages of physicians, nurses, and allied health professionals will also require health systems to rethink how and where care is delivered. The pandemic has caused most hospitals and health systems to experience greater financial distress. This margin impact will be compounded by significantly lower non-operating investment income following record declines in stock market performance and record low interest rates. Skyrocketing unemployment claims will also result in more uninsured patients seeking care. However, the pandemic does provide leaders with a cover to accelerate innovation and change in an industry that has traditionally been slow to adopt. Maria will now share ECG's 4 imperatives.
Thanks, John. Some organizations have proactively addressed the redundancy, duplication, and waste that is pervasive in healthcare today. These efforts may have been prompted by the trends that John just described, the vulnerabilities of healthcare's economic model that were the subject of the previous webinar in this series, and or the intensifying pressure to demonstrate better performance with increasing scale. Systems who are just beginning this journey or focusing anew on this work may be wondering where to start. In our view, there are 4 imperatives for health systems looking to advance their integration and rationalization efforts. Capitalizing on technology innovation for business tasks, eliminating unwarranted clinical variation, designing a platform for delivering and coordinating care across the continuum, and implementing a capital asset plan that supports integration and rationalization. We'll now explore the essential considerations related to each imperative in more detail. So let's start with how organizations can capitalize on recent technology innovations to drive cost savings within business tasks while improving the consumer experience. Achieving economies of scale and greater efficiency through back office synergies, including the integration of revenue cycle operations, is typically an initiative that health systems tackle early on. And while health systems that are migrating from a holding company to an operating company can realize significant gains in these areas, resistance to giving up local autonomy typically is a barrier that needs to be overcome. Next generation improvements in this area will focus on scheduling, coding, billing and collecting, and the speed of just about every aspect of a healthcare transaction. For example, digital tools that facilitate self-service options and 24/7 access allow consumers to schedule appointments and complete pre-registration on their computer or mobile device. This enables health systems to streamline patient access processes across their network, eliminating excess phone calls, minimizing manual information entry, and optimizing staffing. At one children's hospital client, outpatient programs had historically struggled to provide timely referral processing and access to care, with new patients routinely waiting 3 to 6 months for appointments, resulting in dissatisfaction on the part of patient families and referring providers alike. The system had no standardized approach to scheduling, templating, evaluating capacity, or assessing and improving access. Several attempts to improve access had previously failed or had been slowed down due to cultural or operational constraints. After creating an Access Optimization 3.0 vision, which described how the outpatient practices should embrace scheduling and patient access, pilots were launched in 2 specialties. Through the pilots, scheduling and referral processing workflows were redesigned, Epic templates were optimized, staff was realigned, and an Epic toolkit for access and scheduling workflows was implemented. By implementing the Access Optimizations 3.0 standards, over 160 net new slots per month were added for each pilot program, and the standardized templates enabled online scheduling for new and established patients, introducing a digital entry point for consumers. The methodology is now being expanded to encompass the remaining programs. In revenue cycle processes, artificial intelligence and robotic process automation offer opportunities to reduce redundancies and improve productivity from authorization management through payment posting. Automating these repetitive tasks allows administrative staff to focus on tasks that require complex human interaction and decision-making, such as patient follow-up, customer service. As John noted earlier, more consumers are now price shopping. For health systems to compete successfully and effectively manage care across the continuum, cost of care data needs to be readily accessible for both internal stakeholders and consumers. Unfortunately, relatively few health systems have trusted clinical and financial data to inform decision-making. Investments in decision support tools, including advanced cost accounting systems with activity-based costing capabilities, are an essential first step to establishing that source of truth. Without the necessary data insights, it is infinitely more challenging to improve clinical outcomes, operations, and financial performance, and to successfully engage physicians in these efforts. So now let's turn to our second imperative, eliminating unwarranted clinical variation. This variation often exists because departments across sites of care have different operational processes and workflows. There aren't agreed upon evidence-based protocols for delivering care, and/or individual physicians use different medical and surgical supplies and patient care philosophies. While some variation in clinical care is necessary to meet specific patient health needs and preferences and can be useful in developing best practices, diagnostic errors, as well as overused and/or inappropriate or non-indicated tests, treatments, and procedures are non-value-added clinical waste. One way to address the variation is to develop and implement uniform evidence-based protocols and pathways. And this provides a forum for discussing topics such as the appropriateness of specific tests and therapies, inpatient length of stay, indications for different courses of treatment, and site of service. Having the difficult conversations with physicians about preferred surgical supplies and the potential to choose less expensive items that don't compromise patient safety can significantly reduce the total cost per patient encounter. Lean approaches can also be deployed to eliminate excess steps from workflows, minimize patient wait times, and replace manual and duplicative data capture processes. Turning episodic siloed care into a coordinated model of care with greater consistency across sites improves clinical outcomes, enhances the patient experience, and reduces overall costs. At one 5-hospital system in the Northeast, colleagues led a work group comprised of hospitalists and nursing leaders to develop and implement contemporary care delivery processes, including a dedicated observation unit, structured interdisciplinary rounds, and redesigned care management roles and responsibilities. As a result, the system was able to reduce its overall length of stay and realized associated financial improvements. Clinical decision support tools integrated into the electronic health record equip clinicians with actionable real-time clinical and financial data to make more informed patient care decisions, enabling the delivery of high-quality, cost-effective, evidence-based clinical care. Adult alerts can also help reduce unwarranted clinical variation and unnecessary duplicative tests. Some organizations are now exploring how to leverage artificial intelligence to enable better healthcare decisions. Without deliberate physician engagement and strong physician alignment, initiatives to reduce unwarranted clinical variation, standardize operational processes, and adopt new technology have limited chance of success. Physician leadership is essential for reviewing clinical and financial performance data, developing evidence-based protocols and guidelines, and holding peers accountable. Alignment vehicles such as co-management arrangements can be used to formalize these efforts, and performance metrics in physician employment and professional service contracts can be designed to support the targeted initiatives. Sean's now going to speak to the remaining two imperatives.
Thanks, Maria. As Maria mentioned, organizations must be able to innovate from a business perspective, as well as reduce variation within its delivery of clinical services. In addition, there are two more imperatives to consider. As we continue on this journey, the third imperative involves designing a platform that delivers and coordinates care across the continuum. The care delivery platform for an integrated and rationalized health system looks dramatically different than what is in place at most organizations today. Transitioning to this platform entails behaving as a single operating unit, achieving tighter alignment with physicians, and rationalizing clinical resources. The past decade has seen a significant consolidation of hospitals and physician practices. However, most organizations don't make the tough decisions about integrating and rationalizing operations and services, so only back office functions end up being centralized. In fact, a recent study highlighted the issue, stating that less than 30% of executives surveyed reported that the M&A transactions they were involved with achieved more than half the projected transaction efficiencies. As a result, most health systems stop short of achieving many of the potential strategic and operational benefits. Regardless of a health system's corporate structure, functioning as a single operating entity is essential. Implementing one model of care with standardized clinical protocols and consistent operational processes will break down these operational silos. In making decisions about service distribution, capital investments, and resource allocation, it's necessary to adopt a system mindset. This must be supported by a system-oriented leadership structure and aligned incentives that reward the desired behaviors. The next step in this transformation involves organizations aligning with physicians. Future care delivery networks will be less hospital-centric, requiring enhanced coordination across the continuum. Low acuity medical services will be managed outside the hospital or at home, and the migration of surgical procedures to non-hospital settings will accelerate. Our work with multiple organizations indicate that between 40 and 70% of client surgical cases are at risk to migrate to the ambulatory setting within the next 5 years. In fact, we recently worked with a client to identify their exposure to surgeries migrating to an ambulatory platform. Our analysis revealed that over 55% of their surgical volume performed in the hospital setting, or approximately 25% of their surgical revenue base, was at risk to migrate to an ambulatory platform within 5 years. As a result, the organization undertook a process to rapidly develop ambulatory capacity and engage with physicians in this effort. To create a network in which patients receive the right care in the appropriate setting, health systems will need to achieve clinical and financial alignment with the physician community. As Maria noted earlier, both physician engagement and leadership are essential for reducing clinical variation and improving operational efficiencies. Deploying EHRs in community practices improves care coordination, facilitates transitions of care, and reduces duplicative tests. Health systems can pursue a range of formal alignment models, such as co-management arrangements, joint ventures, clinically integrated networks, and accountable care organizations. Successful collaboration with physicians through these and other models enables health systems to deliver a more integrated and coordinated model of care. Furthermore, it's increasingly difficult for health systems to meet all of the healthcare needs of their communities. As such, more organizations will need to rethink and potentially rationalize the clinical services they provide. This is true for smaller health systems that lack the population base and physician complement necessary to provide certain services, and for larger multi-hospital systems that serve multiple geographic markets. Discussions surrounding the scope and services offered at each location and the distribution of services should be informed by an assessment of the health system's clinical portfolio that weighs multiple factors, including quality implications, community access, market competition, clinical expertise, and financial viability. This assessment should identify the clinical services that should be centralized, co-located, rationalized, or eliminated to strategically optimize care delivery across primary and secondary markets. Consolidating services or eliminating them entirely are difficult decisions, but may be the only way to remain viable and continue serving the community in some capacity. Assembling the components of a care delivery network and developing physician alignment models are important steps. Without the hard work of clinical and operational integration and the difficult decisions related to the rationalization of clinical services, the benefits are limited. As we move to slide 13, our final imperative is to implement a capital asset plan that supports integration and rationalization. This will entail rationalizing the current capital assets, creating adaptable and flexible assets, and developing an integrated technology ecosystem in order to support both bricks and clicks. For a majority of hospitals, capital asset planning is currently reactive and focused on immediate needs to replace equipment that breaks or address operational and/or capacity constraints in a single clinical area. The absence of long-term thinking leads to inefficient use of resources and higher capital costs. Instead, health systems should conduct an assessment to determine which of their facilities require upgrades, can continue operation with maintenance, should be repurposed, and should be phased out. In creating a strategically oriented capital asset plan, health systems will also need to establish how many assets, i.e. beds, operating rooms, exam rooms, imaging equipment, are needed in which locations, and evaluate whether all existing locations should be maintained, which will often require difficult conversations about consolidating locations. Determining the best short-term and anticipated future uses of available capital assets will increase revenue and decrease costs in the long run. An example, one Midwest health system developed a growth plan for its physician and associated ambulatory services. The ambulatory strategy focused on 4 categories: geographic growth and access, clinical programs and service growth, consolidation of existing practices, and optimizing of existing practices. We helped the organization with this planning process, and through the planning process, the organization determined that ambulatory services were generally well positioned geographically. That means the focus now shifted on maximizing the utilization of those existing assets and reducing the number of physical clinic locations. This included a few options. 1, creating a new hospital-based ambulatory destination center, renovating the existing ambulatory destination center to accommodate growth, strategically growing key services in the existing MOB, and finally relocating and exiting 9 clinic locations. As a result of this consolidation and the conversations that were required, the organization identified and was allowed to grab nearly 100,000 square feet of space to repurpose that for other growth initiatives. So when designing and building these facilities, flexibility and adaptability are critical. Ambulatory care sites in particular will need to accommodate multiple clinical service lines, diagnostic and therapeutic services, and physicians and specialists on any given day. Standard room sizes, limited customization, and efficient layouts will maximize the use of space. Similarly, inpatient rooms designed with the flexibility to quickly transition to ICU capabilities when needed is a best practice. Although upfront costs will be higher, designing flexible facilities to support future plans will ultimately save time and money. Healthcare organizations also need to develop an integrated ecosystem to virtually engage with patients. Patients are increasingly engaging with providers via telemedicine to receive remote diagnostic and therapeutic care and interacting with online portals. The COVID-19 pandemic has accelerated the technology adoption curve. We've worked with multiple health systems to determine how to rapidly bring to market telehealth services to ensure their patients have the ability to receive the highest care for routine services. This transition to new access channels drastically changes the facility and space needs for health systems, reinforcing the importance of building flexible and adaptable spaces. That completes the 4 imperatives healthcare organizations need to achieve success in their integration and rationalization efforts. For organizations that have embarked on the integration and rationalization journey, they realize both measurable and qualitative benefits in 4 key areas: patient experience, clinical outcomes, physician engagement, and financial benefits. Let me give a recent example, recent client example, and maybe this will help kind of bring the interplay between these key areas home. We recently worked with a client who engaged with their physician community, both employed and independent, to structure a co-management company charged with managing the musculoskeletal services across their multiple hospitals. As a result, the physicians increased their engagement with the system as they were given vestiges of control related to clinical and operational performance within the system and across that service line. Then COVID hit. When COVID hit, patients no longer wanted to receive the routine orthopedic care in an inpatient or an acute care setting. Given the system's proactive approach to integration, rationalization, and engagement, they were able to pivot from inpatient to outpatient, allowing over 75% of their patients to receive orthopedic care in an outpatient setting while still achieving great clinical outcomes. This helped reduce the financial loss the system experienced while providing patients and physicians with a transformed way to work and receive care. At this point, I'll turn the webinar back to John, who will walk us through the integration and rationalization path. John, the floor is yours.
Thanks, Sean. For organizations just starting down integration and rationalization path, the time, effort, and leadership commitment required to achieve gains in clinical, operational, technological, and financial performance are significant, and the cultural and political challenges are real. An organization's integration and rationalization stage will influence which of the specific initiatives that we just reviewed are being addressed. Starting with revenue cycle and physician alignment initiatives can provide some initial wins for organizations. Those who have made some progress are more likely to be tackling access and scheduling and/or standardization of clinical and operational processes. Data-driven decision-making and clinical services rationalization are typically addressed by organizations that are much further down the road. An assessment of multiple domain areas for one 3-hospital system in the Southeast identified operational and financial performance improvements of $19 to $41 million on a recurring annual basis. This included opportunities in revenue cycle, clinical operations, compensation, benefits, and productivity, payer strategy, IT, facilities, clinical leadership structure, and professional services contracts. While benefits are greatest for the initiatives being implemented by the most advanced health systems, these organizations probably face the lowest degree of urgency for achieving financial and operational improvements. Realizing the benefits of integration and rationalization requires a journey, not one-time initiatives. So ongoing leadership commitment is a prerequisite, while physician alignment engagement are essential. Initial achievements and improvements reveal additional opportunities to address and provide a platform for the next stage of work. To compete effectively and make healthcare more affordable, economic and clinical integration, as well as rationalization of services, are the essential means to consistently improve processes and outcomes and attain a lower cost structure. I'll now turn the program over to Andy for our second polling question.
Thanks, John. So our second polling question reads, which integration and rationalization initiatives has your organization completed? In this polling question, you'll have the ability to select all that apply from the following responses: revenue cycle, access and scheduling, standardized clinical and operational procedures, data-driven decision-making, and clinical services rationalization. And while you're looking to complete the polling, I'll remind everyone the first polling question, which related to what stage of integration is your organization in, 46% of you said that you were developing, and 54% said that you were in a maturing stage of integration. So we'll see which areas you're focusing on here as we wrap this particular question up. And let's go ahead and see what the results are. So it looks like we have 78% have revenue cycle, 67% access and scheduling, 22% standardized clinical and operational procedures, 56% data-driven decision-making, and 11% clinical services rationalization. John, any thoughts on these poll results?
Well, I think the poll results are indicative of people's assessment of where they are on the integration and rationalization journey. It's clear that revenue cycle, where in many cases the services have been provided, the improvements that organizations are making in that area are related to blocking and tackling and ensuring that they receive what they're contracted to receive. Access and scheduling are major focus areas right now, particularly post-COVID and the recovery of that, and getting patients who are or have been frankly afraid to come to the hospital or other acute care settings for services are a real high priority for most organizations. I think it's encouraging to see that there's more organizations, over half of those participants indicated the data-driven decision-making is an initiative that they're focused on. I think that's very encouraging. I think that from a standardization of clinical and operational procedures, I would see that as, again, an area of opportunity, and it's an area of opportunity for most hospitals and health systems. And as one might expect, where people are in terms of clinical services rationalization is pretty much what our experience is with our clients, and that is that very few health systems have gone through the process of focusing on where services should be provided based on the care needs of their primary and secondary service areas. So those are my thoughts, Andy.
Thanks, John. That's insightful. And recall that 0% of our respondents in the first question said that they were in an advanced state of integration. And we do know from our experience that those that are pretty advanced in terms of integration and rationalization, they've addressed those tough questions around standardization and clinical services rationalization. So the results are good. All right, let's wrap up with the presentation. And here on slide 17, first I'd like to thank John, Maria, and Sean for their insightful comments and a really, really super interesting white paper, which I hope you all have the opportunity to download from the ECG website. It's evident that healthcare organizations can realize the benefits of integration and rationalization by focusing their efforts on the four imperatives that Maria and Sean spoke to: capitalizing on technology innovation for business tasks, eliminating unwarranted clinical variation, designing a platform for delivering and coordinating care across the continuum, and implementing a capital asset plan that supports integration and rationalization. So at this time, we'd like to move to the questions and answers section of today's webinar. And I'd like to thank the individuals who provided the four questions that we have. But before we do move on to those, just a reminder to our audience to please continue to enter your questions into the questionnaire pane if there's others who would still like to submit those. And I'll ask as many questions on your behalf as time permits. With that in mind, our first question is going to be a question as follows. My organization has started down the integration and rationalization path multiple times. However, the health system is never able to achieve any meaningful results. How does an organization overcome the political and cultural challenges and attain the benefits of integration and rationalization? John, I'm going to direct that first question to you.
Thanks, Andy. I think it's our experience that hospitals and health system leaders strive to achieve meaningful and sustainable results for their organizations. However, changing culture, current processes, and community perceptions are part of integration and rationalization initiatives. Have proven to be difficult, and it's been very hard for these organizations to accomplish meaningful, measurable progress to accomplish these efforts. And when we see challenges that they can't overcome, the result is the continuation of the status quo. It really takes significant time, energy, effort, and leadership commitment to achieve gains in clinical, operational, technological, and financial integration and rationalization. Realizing the benefits of integration and rationalization, as I said before, is a journey. It's not a short-term project, so ongoing and focused leadership commitment is required to stay the course to performance improvement.
Thanks, John. That's a great response. Let's go on to the second question here. This one reads, implementing the imperatives discussed earlier in the webinar may take significant financial investment by an organization. When should an organization expect to see the total cost of care decrease and realize cost savings? Maria, do you want to take this one on?
Sure, Andy. So organizations will not see the total cost of care decrease simply by addressing one or more of the imperatives we discussed earlier. In fact, the financial implications of integration and rationalization come through margin improvement, not simply cost of care reductions. So depending on the specific targeted initiatives, positive results can be achieved in as little as 3 months, while others may require 12 to 18 months or more. For organizations that are in the advanced stage of the integration and rationalization journey, they'll see the greatest margin improvement because they've been engaged in these efforts the longest.
Maria, thank you. A third question that has come up, and Sean, I think I'll direct this one to you. The healthcare industry has been talking about rationalization for years, and no substantial change has really occurred. What makes this time different?
Yeah, thanks, Andy. That's a good question. I think there's a couple things. One, I think right now, COVID is really testing the healthcare industry's resilience. Even before the pandemic, many independent hospitals, small health systems were questioning their sustainability with good reason. We recently developed a financial and operational health index that stratifies U.S. short-term acute care hospitals. We looked at current year and a 4-year trend of operational and financial metrics. And in looking at that, our findings from this index, it suggests about 35% of hospitals were marginal, at risk, and another 27 were technically failing, with the latter characterized by negative operating and EBITDA margins and experience expenses growing faster than revenues. I think providers will continue to face challenges, including aging, more clinically complex populations, a return to high national levels of uninsured individuals, pricing pressures, cost escalations, aging physical plants. The other thing that's going to happen, and we're seeing it, I think we touched on it earlier in the webinar, the migration of diagnostic and procedural cases to ambulatory environments will also accelerate, and the revenue and the cost profile of those surgeries moving is different than when they're done in an acute care or in a hospital setting. So inevitably, some hospitals just won't survive. Given the financial challenges health systems are facing, rationalization is an avenue for optimizing operating costs and achieving long-term financial sustainability.
That's definitely a key takeaway from both the first white paper on the economic condition being in critical condition, as well as this paper that focuses on integration and rationalization. It will be a tough road ahead for some organizations. There's no question. And while others, certainly will have the opportunity to thrive. I have one other question here. Actually, it looks like we may have time for a couple more questions. I'm going to direct this next one back to John. This is, rationalization is often known as cutting healthcare services. Why would an organization whose mission is to provide health quality, accessible care to the community, ration care?
Andy, that's a really great question, because rationalization involves making something more efficient and effective. We understand consolidating services or eliminating them entirely are extremely difficult decisions, particularly given the widespread belief that hospitals and health systems should be all things to all people. These discussions become politically charged as emotions within the medical community and the community at large often run very high. However, to optimize care delivery resources and lower the overall cost structure, the rationalization of clinical services is not optional, but it's required. In fact, it may be the only way for a hospital or health system to remain viable in continuing to serve the community in a more right-sized manner.
Makes sense. John, actually, this is probably a good time, and it's one of our questions that has come through. Would you mind repeating the definitions of integration and rationalization that you started the webinar with?
Sure, Andy. Integration is defined as forming, coordinating, or blending into a functioning or unified whole. Again, for hospitals and health systems, really integration means implementing common operational processes and workflows, adopting evidence-based protocols and clinical pathways, and approaching decision-making with a system mindset. We've seen many hospitals come together into systems, and each hospital continues to operate as its own silo. What we're really talking about in integration is getting that system to function as a system and to think as a system and to plan and organize its clinical services as a system. To rationalize, we talk about a research-based managerial principle to make something more efficient and effective, usually by combining or stopping particular activities with the appropriate workforce to support those care delivery needs. In healthcare, rationalization is more likely to centralize corporate functions and/or alter the scope, mix, and/or distribution of clinical services. As an example, in some situations where we find hospitals providing open heart services at multiple locations with very low volumes and not optimal outcomes, we try to work toward the consolidation or rationalization of that type of service to one facility where you can improve volume, throughput, efficiency, outcomes, delivery, etc. Hopefully that answered the question.
Sandy, thank you. I just got one other question that came in, and I have to ask one of our panelists to take this one on. It's a question we deal with a lot, and this is the question of, where do you see leadership of integrated health systems moving in the future? Physician executive versus traditional hospital health administrator. And I think it's fair to say that we see a future of both. But John, do you have any particular perspectives on this and where the industry might be headed?
Yeah, Andy, I agree with that. I think that physician-led, professionally managed, integrated systems is the way, and it should be done as the way we go into the future. I think that there are a number of physician executives that do a tremendous job, and those systems that have those are fortunate enough to have those leaders that are then supported by professional management staff members is really key to the organization's success as far as the dyad model, if you will, to care delivery.
Hey, John and Andy, this is Sean. If I could jump in as well. I think when you identified the dyad leadership model, I think you hit the nail right where it's supposed to be hit. I would also say in certain situations, a triad leadership structure where we bring in the the non-physician clinicians, so kind of a chief nursing executive, and kind of bring a three-way or a triad system into play, just thinking about how we continue to evolve care and make sure that we have all the necessary players at the right table at the right time.
Sean, that's a good example. And for those advanced organizations that have taken on standardization of clinical and operational procedures, as well as clinical services rationalization, or putting in place system-wide service lines, for instance, across a regional system, we frequently see that highly integrated triad type of leadership structure at the service line level, and it makes sense that at the system level we could see that as well. So I'm going to go ahead and wrap us up then. Thank you all for a terrific, insightful presentation. This concludes our formal program. Please note that if you asked a question that we were unable to get to, we'll follow up with you after the session. I think we got to most of those, but there may have been one or two that I overlooked. We would also like to make you aware of ECG's extensive library of thought leadership on COVID-19. Visit our website at www.ecgmc.com to learn more about these and other relevant topics. I'd also like to, again, thank all of you for attending today's presentation. If you have any additional questions or comments, please don't hesitate to reach out to one of us via the contact information provided in the handouts. And one final reminder, we would greatly appreciate it if you would take a moment to complete the electronic survey upon exiting today's program. As stated earlier, ECG will make a $5 donation to Doctors Without Borders for every survey submitted. Thank you, and everybody have a good day.